guys, welcome back to another episode of Gait Guys Podcast. This is 138. Sorry about the mix-up on that 137 and all the social media posts. We just got into labeling them wrong, and that's our mistake. But anyways, we got a great show lined up for you today. Only a few topics, but we kind of go deep into some rabbit holes today. Ivo goes into a lot of neurology, running with toe extensors and the importance of the extensor pool, if you will, of the central nervous system in facilitating postural muscles and the importance in running and a personal experience that he had. We're also going to be talking about fighting for your gait neurology, at least that's what I call it, and maybe why the bird dog is a bit of a neurologic cluster, if you will. And we're going to talk into ACL and ACL rehab and maybe why some of the social media talk about getting your ACL done, not having to have your ACL reconstructed is maybe not such a great idea, depending on who you are. We'll talk about the crossover gait again, just because we can't help ourselves. We're idiots. And then we're going to talk about the hip flexors and maybe how the hip flexors aren't so important in hip flexion during running. Maybe they're doing something a little bit differently. Anyways. Sponsor us on Patreon. If it's not up, it will be soon. We'll just look for it on social media, but we'd appreciate your donations because we're doing some more stuff here and it takes time and that stuff costs money. So anyways, appreciate it. Hit the donate button over on our website once we give you the go ahead. So anyways, enough jibber jabber. Let's get on with the podcast. All right, we're back for another podcast here. How you doing, Ivo? You guys just got back from a little vacation. Where'd you guys head to this time around?
We were up in Grand Teton National Park up in Wyoming.
Oh, nice.
Checking out some of the fishing and hiking and that kind of stuff. So it was
like to get cool. There. Here it's beautiful up there.
It is. It's a little bit of a ride. I don't know if it would be farther for you or shorter for you. It was about almost 10 hours for us. So
that's quite a hike.
It was a bit of a ride. Yeah.
Yeah. Did you guys take the trailer up there?
We did, and we hung out for a week and fished. And like I said, hiked a lot, saw a lot of moose. It was good. Nice.
Very good. Well, we've continued to plug away here at the podcast and on the, on the blog and on social media about all kinds of things. And I took particular interest to your piece on your running. You were running one day and you had some knee pain, and then you wrote about convergence and divergence of neurons and neuronal pools. And I thought it was very interesting, and I thought maybe we could just dialogue that and see where it goes, because it brings up the topic of being aware of what's going on and not just going out for a run, but making your run a little bit of a body awareness meditative event. A lot of people go out and just kind of, go through the motions and think about their day, and that's all great and fine in making it a moving meditation, but occasionally it's nice to make it a meditative thing on body awareness and what's going on with your system, particularly when you're in pain or you've got some kind of a problem that is just nagging at you. And I think the wise runner is one that will start monkeying around with their mechanics a little bit and seeing how they can avoid pain and playing around with limb position, foot position, more abs, more posterior tilt, more anterior tilt in the pelvis, more core engagement, more glute engagement, looking at knee tracking and stuff like that. And your experience was very much along those lines, and you've tended to focus on the extensor pool. And I'd love to just hear a little bit more about that. Maybe you can, expand on it, but it was worthy of, I think, adding into the podcast, because not everybody reads as much as we do, and they don't read into our blog or social media posts at times because they can be a little bit on the long side, and people like the cookbook 2 or 3 bullet point thing. But let's expand on that a little bit. Maybe some people who didn't read will rather listen to it. So if you don't mind and you want to, go ahead.
Sure. I run, as a lot of people may know, and mountain bike. And I was out on a run one morning, and I have a tendency to develop patellar tracking issues, and that's largely because I have femoral retrotorsion and internal tibial torsion, which means that my foot points in when my knee points straight, and I need to rotate it out to get a good progression angle, and as a result, I create a conflict and patellar tracking issues at my knee. So without bothering that down more. And then I've got a forefoot supinatus as well, which means that my forefoot is kind of inverted with respect to my rear foot. So I have a tendency to develop some tracking stuff. And if I don't have good ratio of muscular recruitment between my flexors and extensors, I have a tendency to develop problems. So this particular morning, there's one section of this trail that I run that it's got a pretty good hill on it, and I was starting to get some knee discomfort, and kind of trying to be aware of what's going on with what's going on with my body. I kind of take inventory, starting at my feet and working my way up, and realized that my feet were pretty relaxed the way I was striking. So all I did was extend my toes a little bit. So I kind of did the lift, spread, reach exercise, but inside my shoes as I was running uphill. And that was enough to create better knee mechanics and get rid of my discomfort at the time for the remainder of the run. So it got me thinking on runs, as I usually do or often do, about posts and things like that I could kind of write about on this. So what exactly happened and what did I do? Well, I fired into my extensor pools, and we've talked here enough on the blog, like way too much probably, about flexor dominance. And your corticospinal pathway basically does distal flexors, okay? Your vestibulospinal pathway basically does axial extensors, and there's some in between there, but we need to have a balance between these two guys, and we tend to be very corticospinally driven a lot of times because of flexed postures and things like that. So we have a tendency to develop too much flexor and not enough extensor tone. So one of the things I always work on in practice with my patients is really having them get good skill, endurance, and strength in their extensor pools. In other words, the muscles which are going to fire axial extensors, which incidentally are largely innervated. Of course, there's some innervated by corticospinal tract, but largely innervated by the vestibulospinal pathway, which receives its information from the cerebellum, which sends its information out to the forevestibular nuclei. The lateral vestibular nucleus information comes down and becomes the vestibulospinal or the lateral vestibulospinal pathway, and that fires our axial extensors and keeps us upright in the gravitational plane. So whenever you fire a muscle, okay, the information travels down the afferent aspect of that muscle. So we have muscle spindles, right? You have nuclear bag, nuclear chain fibers, and they travel via these fibers called 1A afferents, and that information goes into the spinal cord. And when it gets into the spinal cord, a couple different things can happen. It can synapse on neurons which go up the dorsal column and tell you where you are in space. It can synapse on neurons which travel up the lateral funiculus of the cord and then cross again to go into your cerebellum, such as the spinocerebellar pathway, or more often than not, they synapse on interneurons. And interneurons are about 30 times as numerous as the other kinds of neurons and other types of cells in our body. So when we're thinking about, neurology, we think about neurons. So neurons are sort of the workforce, they do the work. And then you have the structural guys, and you have 4 of those technically. You have astrocytes, which create the framework for everything. You have oligodendroglia, or Schwann cells in the peripheral nervous system, which myelinate the cells. You have microglia, which largely act as the macrophages of the system. And then surrounding ventricles, we have ependymal cells. So the neurons, getting back to that, this neuronal pool, we have regular neurons which go from point A to point B, end on some end organ, and have that function, in this case musculature. Or we have interneurons, and interneurons are about 30 times as numerous as regular neurons. So when we have information coming into the cord, more than likely it's going to synapse on interneurons and interneuronal pools, so groups of these interneurons hanging out together, rather than just like a one-to-one connection. We like to think of it as like, it goes from A to B, and it's that simple, and really it's not. It goes from A to B, but it also goes to C through Z, prime, and goes through a number of these different pathways. And then all these interneurons have connections with other interneurons as well as neurons, which can basically come to a sum total of either plus or minus, right? Because the nervous system pretty much, if we're talking about neurons, we're either firing an action potential or we're not firing an action potential. So we're trying to get to that, all or none sort of thing, and it's the sum total of pluses or minuses that will determine if a muscle fibers. So if that sum total is plus and it goes to flexors, we fire flexor muscles, and if it goes to extensors, then we fire our extensor muscles. And so before we go further, we should talk about two other quick principles and then kind of bring it all together. So in the nervous system, we have two large principles. So we have lots of receptors in the periphery, which come down to fewer receptors in the cord, which come down to, or neurons in the cord, which come down to fewer nuclei or neurons in the brain. So we have this principle of convergence, information from multiple areas converging. So you might have, let's just take a number, 1,000 receptors in the periphery feeding down to, 100, which are in the cord, and then maybe fewer than that in the brain. And the numbers are, much more staggering than that. But this is the principle of convergence. So a lot of information gets condensed down to a little bit of information. And this is important for things like you see people with, facial pain and tic douloureux and headache pain sometimes. Sometimes these things can be due to cervical spine dysfunction, and that's because the face, the trigeminal nerve does the face, one of the cranial nerves there, has 3 different divisions, and those divisions share the same second-order neuron. In other words, that convergence thing we were talking about, with the upper 4 cervical nerve roots. So you could have upper cervical dysfunction, which could be causing facial pain, or vice versa. So we have this principle of convergence of things. And then we have the other principle, which is divergence. So information coming out comes from one neuron to more neurons to multiple neurons to end organs. And we see that in the sympathetic and parasympathetic nervous systems, where we have one area which can affect multiple ones. A perfect example is at the cervicothoracic junction, the junction between your neck and your upper back. You've got the seat of our sympathetic nervous system. Our sympathetic nervous system does things like controls how fast your heart goes and how deep you're breathing and how dilated your pupils are and all kinds of other functions there. Well, it's well known, and if you look through literature, you can see it. When you manipulate, mobilize, massage, affect the cervicothoracic junction, you're affecting this nucleus, or this beginning of the sympathetic nervous system. And the sympathetic nervous system is far-reaching, so effects in that one area can cause large effects elsewhere. So we have convergence, lots of information getting condensed down, and divergence, information being dispersed out to multiple areas. So getting back to what I was talking about with the firing my extensors. So basically what I did is I extended my toes. I did the lift, spread, reach exercise, like I said, inside of my shoe. And as I did that, I was just providing more afferent input into the extensor pools, which in turn fired more extensor pools. So, something as simple as lifting your toes up helps you to fire into the posterior compartment of your leg. And you can try that experiment. It's way easier to recruit your glutes with your toes up than it is with them flexed or crunching down, just as far as that. And just try the experiment. Don't believe me. Go to your favorite squat rack and crunch your toes up as much as you can. And do a potty squat, sort of a back squat, or you can use a Smith machine or something like that, and then do it with your toes extended and lifted. And of course, you're going to be able to lift much more because we're just firing those neuronal pools. So we take advantage of this a lot of times when we're doing rehab, in the office with patients, just getting them to do simple little things. And I know you do this all the time in your office, Sean, because I've been at your office and, hung out with your therapist and done that kind of stuff. And, you guys are doing this as well. It's just a matter of trying to be, I don't want to say smarter, but get more bang for your buck, and that's kind of what it's all about when it comes to rehab. Just like I know a lot of people are, you talk about tonic neck responses or cervical extension responses, and, oh my God, those are primitive reflexes and they're only, well, when you have a nervous system dysfunction, and dysfunction a lot of times is a physiological lesion. In other words, it's not a boo-boo we can see on an MRI or a CT or something like that. It's basically like an electrical short. You can't see really an electrical short except with a meter. Well, the meter in this case is function. So when we have a physiological lesion, we are able to alter that a lot of times with what we're doing, whether we're using a tonic neck response or something like that. And don't believe me, take a needle EMG, stick it into your upper extremity extensor muscles, lie down on a table so there's no gravitational input, rotate your head to the side where the needles are, and you'll get firing of the motor units in that area. And the reason is because of some persistence on a small level of the tonic neck response. And when we lose some of that cortical inhibition that occurs from the brain, because most of the fibers coming down are inhibitory, not excitatory, like we like to see, because we need to control the excitatory stuff that's going on. When that becomes disinhibited, that's when we start to see pathology and dysfunction. So it's just a matter of trying to kind of harness these things and put them all together. And just having somebody do something really simple like extend their toes while they're trying to contract their butt can make a huge difference as far as their function. And that's these principles of, we talked about it in the post. It was June 25th. On our Facebook page, and I believe it was published a few days earlier on the gateguys.com website as far as that. But you can go back and check it out. It's called The Power of Facilitation, and just a simple post. It'll take you about 10 minutes probably to read through and look at. But anyway, just sort of your little neurological tidbit for the day, something you can use. I use this stuff every day, and I know you do too. So.
Mm-hmm. So translation, if you're trying to get more glute, which is a hip extensor, more quad, which is a knee extensor, or an eccentric control or reflection, if you will, firing your toes will get those extensors to work a little bit better. Translation, if you're having troubles getting your glutes to work, fire your toe extensors. If you're having some patellar tracking like you did here, and it's an extensor problem, firing your toe extensors might help. If it doesn't help, it doesn't necessarily mean it's not a quadriceps extension issue. It may be an isometric inability to control loading, the loading response. It might be an eccentric problem. It might be, a concentric problem. But, so that's kind of the translation, right?
Yeah, you could use any extensor. You could use your tricep if you wanted to. Mm-hmm. The thing is, again, going on that principle of trying to get the most bang for the buck, your foot has way more cortical representation than your tricep. Mm-hmm. So using your foot, you're going to get better. You could also, a lot of people, when you see sprinters, okay, so do this, go to YouTube, right? Look up a couple sprinters and watch these guys take off. The people that keep their head extended have faster acceleration than the people that flex their head and push forward. Why? Because they're firing into the extensor pool. And we've talked about this on posts. I forget what the dude's name was, but he's a very famous runner. That we've looked at, and we've looked at multiple ones and talked about this.
I think it was Michael Johnson, yeah.
It may have been, I don't remember. But the point is, you could use any extensor. And firing into that doesn't mean we just need to be extensor dominant, which I've never seen, but I'm sure exists in some people. But the point is we're not using them enough, and your brain will become warped in the direction of what you use mostly. Right? So if you listen to like Dream Theater all the time, and bands like that, like that I listen to, then you just tend to like that kind of music rather than like Kenny G and, stuff like that. So.
Yeah, so great segue there. But if you look at a lot of sprinters, they tend to run with their fingers abducted and extended, and the wrists a little bit extended. I know there's a group of people out there that like the pulsing and whatnot, and they tend to want to grip the thumb and index finger, I believe, and don't quote me on that, but they're more into flexion, which we disagree with. So it's funny because in the shuffle walk and the toe up walk, walking on a foot tripod with the toes extended, but particularly in our shuffle walk or in the Texas walk exercise that we have, it's funny, you watch the client moving real slowly, working on toe extension and ankle dorsiflexion, and you will look up and they will be extending their wrists and their fingers to try and, it's a subconscious thing, and a lot of them will comment on it going, oh my God, I'm firing my fingers, into, they don't say that, they're not going to say I'm firing my fingers into extension to, summate the extensor pool. They may, depending on who they are, but they're not going to say I'm trying to hit summation on the extensor pool, but it's in fact what they are doing, and you draw their attention to it, and some of them will say, look at my hands, and I'm like, yeah, I know, I noticed it, and I know exactly what you're doing on a neurologic level. So it's funny, you will see that. Give the shuffle walk, go over to our Gait Guys page and type in the Gait Guys shuffle walk and give it to a couple clients and look at their hands, and they will fire into their extensors. Probably at least half of them will. So it's not coincidence, it's neurologic. So
yeah, and you'll actually be able to help them do the exercise better, like the lift, spread, reach exercise that we use all the time. I'm always showing people like use your hands, and they'll be doing it automatically while they're going through that. So it's a tool to help you as well.
Yeah.
But yeah, just try that next time you're running. Flex your head forward and then just extend your head. You'll feel the difference. I mean, you can see the difference, neurologically. It's just taking advantage of, well, not really advantage, but paying attention to what's going on with people. And some people have too much, of one and not enough of another. And diverging just a shade here, I had a gal in to come see me. She came from Canada, actually. Which you were born in Canada, so I imagine you could have seen her when you were up there. But anyway, she came down to see me, and she had runner's dystonia, which is, I have to say, is something that I really didn't have any experience with treating prior to meeting this gal. But a lot of it was she had really dominant flexors of what was going on, and a lot of what we did was real simple stuff, but a lot of it was working on proprioception and really getting her to balance out and start to use her extensor pool to a much greater degree. And I've got video that I'll post, pre and post. I'm putting together we'll call it a post, I guess, for right now, which is stuff on runner's dystonia now. So we can get that out there, and it's turning into quite a project. So it may end up actually being a couple posts. But this gal gave me permission to use all of her video footage and stuff. And it's pretty cool because we can point out stuff pre and post. And it'll probably end up being more of a YouTube video that we've got going on, but the same idea, that you're seeing a certain part of your nervous system sort of hijacks the other part, and you get too much. A lot of times it's flexor, but you get too much flexor tone or too much tone in one area, and it just starts to create problems. Not only because you get the reciprocal inhibition when you fire your flexors, you inhibit your extensors, but there's also a pathway through the brainstem that has to do with the reticular formation that becomes inhibited. So you get this double whammy, like inhibiting the extensor's effect. That's why it's just so important to have great extensor function.
Well, and that brings to light the thoughts that we like to discuss, that a lot of the clients that come in with problems is because they're kind of fighting the underlying neurology. They've got an unstable joint, and they're over recruiting into a flexor dominant, or we'll use that as an example here, which inhibits the extensors, and the homework quite frequently is to retrain the motor pattern to get them into the extensors. So you can either work with the nervous system or you can work against it, which is why, we've commented on the blog post many times that the typical quadruped-based bird dog is working against the neurology. It's not that it's a bad exercise if you're trying to get some coordination, unique coordination, I will say, of the core for balance, but it's not typically a clean motor pattern neurologically. And so, it's why we posted on that runner with the high knee drill that he was actually doing it correctly. And when you translated him downwards, you can look that somewhere around mid-June on the blog and on the Facebook post there, that it's what he was doing was the correct neurologic pattern, whereas the bird dog is a conflicting motor pattern. So it's not an opposite arm, opposite leg, clean neurologic pattern. In the bird dog, one limb's moving into flexion, limb is moving into extension. That's not how we move in the gait cycle. It's not how we crawl either. So don't, as we said in those posts, don't confuse bird dog as a crawling neurologic gait-based pattern, because it's not. It's actually a very conflicted pattern. And it plays over very strongly into the posts that we have done in the last 2 weeks on arms crossing the body, and even in today's post, which was June 29th, where we showed some young kids who were neurologically still young and still trying to put the nervous system together, and they were running, and they're driving that knee across the midline and an opposite arm in the upper body, obviously upper arm, across the body. So they're doing a lot of this twisting motion. So which again is a very immature pattern, but it again shows the mirroring and the shaping of arm and leg patterns, even though we know that the lower limbs kind of dominate the driver of that pattern. But I don't know if you have any dialogue on that with the bird dog and how it's not neurologically correct. We've certainly talked about it before, but again, you can work with the nervous system or you can work against it, and there's some preset wiring that makes sense. And if you're fighting that, you may be actually driving some incongruent neurologic patterns for movement and stability, or at least primary movement patterns. So we've been kind of hitting that lately a lot on the blog, and again, it comes up here again just out of your discussion on extensors. So
yeah, there's that saying, you don't fight a river or you don't fight the ocean. You kind of have to go with it, and the nervous system is kind of like that. So the more we can work with it and play nice, the better results you're going to get much quicker a lot of times. Not to say that there's not like little quirks and shorts and things like that we have to kind of work around or reprogram. But for the most part, neurology trumps, a lot of things. And we talk about this and have talked about it multiple times when it comes to like propriosensory exercises versus strength or endurance training or things like that. It's just, propriosensory exercises trumps it for pain control, trumps it for muscular function. When you look at the studies, when proprioceptive exercises are incorporated in rehab programs, people do better for longer periods of time. And that's just because you have to have that feedback component to the central nervous system, via the cerebellum, vestibular nuclei, and things like that. And if you don't have that, then you start to have issues. So yeah.
So I've been pretty heavy on Twitter lately, at least following a lot of the influencers, let's just say, in the physical therapy, rehab, neuromusculoskeletal world. And I'm going to leave some names out of this, but last week there was some physical therapists, and actually I'm not even going to, it was put up by, excuse me, a physical therapist, but it became more of a dialogue of a bunch of people agreeing to something that I don't know that I completely agree with. And one of them was talking about the myth that you can't play sports without a anterior cruciate ligament, an ACL ligament, and they stated that there was a fact that 40 to 50% of patients with isolated ACL tears can cope without an ACL and return to pre-injury sports. And they quoted the Hurd, H-U-R-D, et al. 2008 and Frobel 2013 studies. And they came to the conclusion, not them, well, I guess it was the study, but it was also this group of folks, that not all ACL injuries require surgery. That high quality strengthening post-injury is a must. The question is it enough? And I think from the study, the conservative summary was that 40 to 50% of isolated ACL injuries in young adults under 35 years of age with concomitant pathology can cope without an ACL for 5 to 10 years post-injury. And I think that might be the... I disagree with this to a large degree, and I think that if you go into the literature, there is really some conflict on this. Everybody's tending to move away from surgery now, and I am very much the same. But I think there are certain parameters that you need to walk about that a little bit more gingerly. This study here, or the conservative summary, whether it was from one of those studies or from the a slide from this that was put up by this therapist, was that without an ACL for 5 to 10 years post-injury. That's kind of a narrow time frame, and the gist was that you don't need it and you can prevent osteoarthritis. But we've written about this before, about secondary instability development, and most patients, and I know this for a fact because I've seen it in my office, they don't, not patients, physical therapists and rehab specialists and coaches and trainers, there's a group there. They don't understand the anatomy enough, and the posterolateral corner of the knee is the most difficult and most complex area of the knee. And the secondary restraints, the capsule, the popliteus muscle, the popliteus tendon, the fibular collateral ligament, ligaments of Reisberg and Humphreys, that posterolateral corner is very dense, and it's supposed to be fairly stable and tight. But a lot of the times in PCL and ACL injuries, and I've seen it in both, that posterolateral corner gets disrupted. And I have had personally enough cases where the ACL was reconstructed, but the posterolateral corner that was also damaged in the injury was not reconstructed, and so they had great restriction of tibial translation on a Lockman's type anterior drawer test, but there was rotational instability, a positive pivot shift. And the one client that kind of comes to mind, he had 2 surgeries, and I finally I wrote after the first one to the surgeon. I said, the ACL looks fine. The patient still is expressing subjective instability playing basketball because the posterolateral corner and rotational instability has not been addressed. So when the reconstruction is done, please address the posterolateral corner if you feel that it gets worthy. So the young kid, he was a star high school basketball player and was hoping to go to college, has the second reconstruction done, and they went in and I think the anterior graft was okay, if you ask me, but they went in and redid the ACL graft, but still didn't do the posterolateral corner. Kid went through his rehab, came back to check me, saying, "Doc, there's still something wrong. I don't know what's going on." And it was the exact same presentation. I said, "Can you get me the surgical report?" And in the surgical report, there was nothing about posterolateral corner reconstruction. And he still had a pivot shift. And I said, they didn't address what I asked them to address. And I said, you need to take this up with the surgeon. So that created a lot of friction. And I did not hear the final outcome on this. And I do not know what's happening to the young fellow, but I don't think he went in for another reconstruction. And, you do not have to have that secondary instability developing right away, which comes back to this discussion amongst this group of folks that you may not develop that secondary instability for 5 to 10 years. So you're getting a little bit of tibial translation and a little bit of tibial spin in internal rotation, the differential spin rate between the femur and the tibia. And so you start to rotate a little bit more, and you start a little bit more translation at that tibio-femoral joint. And over time, which is probably going to be greater than 5 years, and maybe greater than 10, but perhaps somewhere between 5 and 10 years, you're going to start to develop some degree of posterolateral rotatory instability, which can create meniscus maceration, which can create more cartilage shearing. And so the gist of this article of the discussion amongst these folks was that not everybody needs an ACL. Maybe no one does. Half the people with an isolated tear can cope very well without an ACL and return to pre-injury sport. I tend to disagree. I agree that they could, but not without a cost, in my opinion, and I have seen it. I have had, and we've even put cases up here with people who had an ACL reconstruction 10 to 15 years post-ACL. They delayed it, and they had significant posterolateral rotatory instability, which was their major complaint in loading. Every time they loaded and turned, there was a rotational event, which caused some quad inhibition and subjective instability and buckling of the joint. So I have seen these cases where the ACL was not reconstructed, and the client said, "I wish I'd had this done." I think, they tended to agree with me that this could have been avoided. Now, again, it's hard to say, but, I've done enough reading, and I know you have as well. And we went through a lot of this during my orthopedic residency of looking at rotational instability as a secondary consequence down the road from ACL non-reconstructs or failed ACL, or an ACL that wasn't actually dialed in snug enough during the reconstruction. So, that posterolateral corner is very sensitive. If you do not know how to assess it, you're going to miss the rotational instability. You're not going to see the pivot shift, and it can be very subtle. There are degrees of it, and I tested on all my clients. I tested on all my ACL reconstructions looking for it, because a lot of clients have this lateral knee tightness, and they thought, "Oh, it's my IT band." And I said, "Well, it may be reactionary because you've got a rotational event here, and it may be a small amount, but it's enough that your brain is trying to find some more lateral stability to hold that tibia back a little bit." And, in enough cases, I see a little bit of pivot shift rotational instability, and when pointed out to the client, they notice it. And if you know how to express it on an exam, they can sense the instability. It's usually with the foot turned in or the tibia internally rotated, and they go into a quad loading eccentric type phenomenon, and they get a little bit of that external spin, and they feel like the joint is going to buckle, like they can't get into the quad to protect. So, and that's when you start pulling in the hamstring to try and posteriorly translate that tibia back. And so anyways, sometimes a reactionary IT band tightness after an ACL reconstruct 5 years, 10 years, 15 years, maybe even 25 years down the road. It might be because there's secondary restraints, because we do know that there's a high incidence of joint degeneration and osteoarthritis even in ACL reconstructions, just because there's been enough damage to the joint after the inciting event, and it's never the same. So I just wanted to throw that out there, because the dialogue was becoming, I saw the number of retweets, and it was getting quite high, and it was a little disturbing that no one was talking about this, and I didn't want to go in and you know what it gets like on social media. There's a lot of arguing and disagreements without substantiation, and just didn't have time that day to get into this. But as I saw it more and more, I thought we would bring it up. I don't know if you have any dialogue on that or not, but folks, you do need an ACL in order to return to sport safely. Do you need to have it done right away? You do not, but you need to understand there may be some consequences of either accelerating meniscal maceration, accelerating cartilaginous shear forces, which could accelerate the osteoarthritic type changes at the joint, and you may get secondary restraint of the posterolateral joint with capsular attenuation, ligament stretching. You may get some symptoms simply of popliteal type pain, posterior knee pain, because the popliteus is reacting because it's being overburdened. So just something to think about. If you've had an ACL tear, partial or complete, don't believe everything you see on social media, folks. But there's a lot of good stuff on social media too. So, anyways, I think I've covered us on both sides of that. But didn't know if you had any comments on that.
I mean, just a couple things, clarification and comments. So, one, the studies he's talking about here, I think that the fact portion of it is it depends, and it depends on the sport.
Sure.
Okay? Like, we have lots of patients that elect to not undergo ACL surgery that are fine. But these are also people that are not high-level athletes, that are doing some of the, foot-dependent sports you would think about, like soccer, where you're going to have a lot of plant and pivot, or football, or things like that. So I think that it needs to be weighed by the patient, making an educated decision if they want it. Because we've seen lots of failed ACL surgeries as well,
sure,
for reasons that you've talked about and others. And, we've got a lot of uninsured people that come to see us, even though we live in like one of the orthopedic meccas of the world when it comes to knees and things like that. But the point is, some people, just like dogs, can do fine without having to have that ACL. Again, I think it depends. And it depends upon their lifestyle and what their goals are and things like that. You are opening yourself up to changes down the road because we're destabilizing that joint. But if you're not ever taxing the joint to the point where you need that, then maybe it's okay for them to not have surgery and undergo conservative rehab and be really strong. So that's just my 2 cents worth as far as what's going on. And then two other just real quick things, if you could do for everybody listening, because not everybody's been listening to us forever, and not everybody understands all the jargon. Really quickly, can you just explain briefly what you mean by the posterolateral complex? And two, I understand you can't like orthopedically test somebody on the air, but if you could just explain kind of like, all right, we're externally rotating the leg and we're doing a drawer, that kind of a deal, to just give people an idea, because somebody might say like, well, I listened to this podcast, and they talked about this and I did this, and man, I had a problem. So that's why I went and see the doctor, and that might help some people out there that are on the fence about this.
Yeah, good points. And I'm glad that you put in that caveat. If you're 50 or 55 years old or whatever age, and you're not...
watch it.
I know. Well, I'm in the 5s now too, my friend. So if you're not a high-level athlete, and you're not going to be a high-level athlete, and your sport is one of, easy running or walking or biking, you probably don't need that ACL right away, and you might not even need it at all. It kind of depends, like you said, on what your demand is on this thing. You may have stepped off a ladder and buckled that thing and torn it, and that was the most physically active thing that you have done and will do for the rest of your life, is just getting up on the roof to clean out the gutters. So that's a completely different person. But if you're going to perform at higher level sports, and specifically multi-axial rotational sports like tennis or basketball or soccer, where you're making these cuts and pivots and you're having to stabilize the joint, push off and change direction, it's a different beast here. Rotational instability is going to show up if that posterolateral corner is dinged, and it may show up in time. So, I mean, if you're 20 years old and you're trying to, make the Germany, actually I shouldn't use Germany, only because they lost in the World Cup there. But okay, let's say it is the German team and you're trying to make their squad. You're probably going to want that ACL reconstructed. So yes, it depends. But if you're in your 20s, 30s, maybe even 40s, and you're going to stay very physically active, you might want to reevaluate the thought of, I just need to do some ACL type rehab and make that thing as strong as possible, and develop these Hulk-like hamstrings that create more posterior translation dominance at the knee to stop that anterior translation, which is what the ACL does. But that being said, posterolateral corner. So, I mean, if you were to sit in a chair and straighten your leg out in front of you, and you would take a knife and cut straight down through the front of your patella, and that would be one cut. And then you're going to go side to side and create another cut. So you're kind of dividing the knee into 4 quadrants of a pie. The posterolateral corner is exactly that. It's the posterior aspect and it's the lateral side. So it's that lateral corner of the piece of pie. And so it's back kind of where your hamstring tendon is. If you reach behind your knee on the outside, where your hamstring tendon comes down, which you can feel it if you bend your knee, that's the posterolateral corner. And in there, there's a bone, a fibula, and the fibula comes up and creates a fibular collateral ligament, which helps stabilize the lateral knee. It's also known as the LCL, and there's the MCL on the inside edge. So it's one of these major restricting ligaments that helps create some passive stability at the knee. So you have these medial and lateral collateral ligaments, and then you got your anterior cruciate and your posterior cruciate, or your ACL and your PCL. Those are the major restraints. You have these secondary restraints, which are less aggressive in terms of controlling these massive translations at the joint, but they're still there as a backup, and they do help create an extra little bit of stability. It's the capsule or the bag around the joint. It's the popliteus tendon. It's the fibular collateral ligament, and some of these actual complex twisted ligamentous structures at that posterolateral corner. And they're there because that corner is very vulnerable to rotation. So if you were to turn your foot in and load, so you're taking your foot, putting it on the ground, turning it inwards like you're dink-toed or toed in, and then you do a squat with your knee going straight forward, you're going to promote rotation of that tibia forward on that femur. And that is rotational instability. When you do the test, you have them on their back, and it's basically a valgus force at the knee with moving from flexion to extension, and you're trying to create some rotation of that tibia. And you will feel, I don't even know if I can explain what it feels like, but you'll feel that the tibial plateau translating forward on that femoral head, to the point where when it's bad, you can actually feel it as you're moving from flexion to extension. You can feel that thing become prominent, and then at that 30-degree point, the IT band pulls it back, and you can actually get a clunk, and it is very uncomfortable for the clinician to feel, because it's a little scary, and the client freaks out because the hamstring kicks in and pulls that thing back all of a sudden, and there's a clunk and there's a sense of instability. You don't have to go that far. Once you get to being able to finesse that test, you can feel the translation. Usually I just back away. There's no point in taking it all the way. You can feel that with a little bit of strain, if it's translating too much, more strain is going to probably translate more. So it's not there unless you've damaged that posterolateral corner, where you've had a varus type stress to the knee, which is kind of a bow-legged stress to the knee over time, or you've dinged your ACL or PCL. So when the damage is bad enough to the ACL or PCL, and there's enough translation of that tibia on the femur, either in the forward or posterior direction, not only do you tear the ACL, but you pull some of those extra ligaments and capsule with it and tear them as well. And that's when you get an ACL or PCL tear, and they're usually complete, which can be arguably, depending on what source you read, up to 80% is considered complete. But you can go into that whole dialogue of, it's the anterior bundle, which is functional. The posterior bundle of the ACL is not functional. So technically you could tear the anterior bundle, leave the posterior bundle of the ACL, and still be functionally incompetent with anterior translation and protection. So I know we're getting a little complex here. At this point, folks, just go into our blog and type in rotational instability, or just look these things up on Google and start educating yourself on this, particularly if you are in that family of ACL instability type issues. So,
there you have it.
We're going heavy on our specialties today. You're hitting the neuro hard. I'm hitting some of the orthopedic stuff. These things are frequently missed, and I see them enough that I'm calling surgeons and telling them, please, you're my go-to guy for the ACL, but I really feel instability here. For this to be successful, please look at that posterolateral corner when you're in there with the scope, because I think it's been trashed. And I've had surgeons call me going, hey, good call, man. I had to reconstruct that thing. One fella had to go all the way over to Belgium and have his done, and I sent him a letter, and the guy called me from Belgium and said, you're a chiropractor? Nice catch on that rotatory instability. We had to put a screw in there to actually, anchor that posterolateral corner. My surgery wouldn't have taken had we not done that. So I appreciate your insight on this. So that was nice. That's one of the career hallmark pats on the back. So anyway, so we're 45 minutes into this. Got anything else you want to talk about? We could certainly yap on about a bunch of other things, and I've got a list of things here, but I was thinking about this the other day, and I do think I wrote a little bit of a post which stirred up the pulsing group, David Weck and his group, and crossover gait. If you're running on a line, you're probably striking the lateral foot, and it's going to be very hard to get off the big toe. And people who run with a very narrow step width, you're probably striking more on the outside of the foot, and it's very hard to get off your big toe when you don't get to your big toe. Go ahead and increase your step width, and all of a sudden you can feel yourself toeing off your big toe, and you can, surprisingly, sarcasm, insert a sarcasm there, you can feel your glute working too. So it's why sprinters have a nice wide step width, big glutes, good toe off. You don't see sprinters sprinting with a lot of crossover. There's not a lot of power there. So is that something you agree with, disagree with, see in your clients? Give me your 2 cents worth, or just say, old hat, Sean, move on.
As far as?
Yeah, just this narrow step width. I mean, you're just not getting into a lot of medial foot tripod loading and big toe off. I mean, it's just, you're on that lateral low gear toe off. You're more on the third, fourth, and fifth metatarsals. The foot is more on the outer edge. You're not getting to that high gear medial tripod toe off. You're not going to anchor that hallux. Is that a predisposer to bunions? We could go down that whole rabbit hole too. But when my clients have big toe pain, my distance runners, I go out into the parking lot with them, and we just have them run a little bit, and I have them run on a very narrow step width or on a line, and help them get in touch with the fact that they're probably not firing their glutes as much, and they don't feel a lot of big toe engagement, and then have them run a little bit wider, and they suddenly feel what I'm talking about. And it's just something I do on a regular basis with my clients, because most people, as you and I know, they have an incompetent foot tripod. They don't get into good high gear toe off. They don't have enough glutes or abs. It's kind of, geez, is that 70, 80% of our practice? Maybe, I don't know. Let's stir any thoughts?
It's all kind of the crossover. And there are neurological reasons for the crossover, and there are musculoskeletal reasons. And most people have a combination of both. I think that there's probably a time and a place for training that way, but it certainly shouldn't be the bulk of your training as far as that goes. Just from a balance standpoint and learning how to handle loads and move your center of gravity. I cross over at times because I run on narrow trails that are single track for bikes, and there's just not enough width to run on something other than that. So you're forced somewhat into a crossover. Again, if you're going to do that, you need to make sure, 1, that your toes are extending, 2, that you're getting adequate hip extension, 3, good ankle dorsiflexion, trying to make full contact with the ground. You're feeling yourself peeling off your hallux rather than the lateral aspect of the foot. And then, the real simple, easy help for a lot of that, a lot of times, is running your arms at your sides rather than across your body. You bring your arms across your body, you're going to move your center of mass across the middle of your body. You're going to have a tendency to bring your legs inward. If you run your arms at your sides, you're going to have a tendency to rely more on your gluteus medius and quadratus lumborum / erector spinae strength. And a lot of people lack that, which is why they do bring their arms across their body, and they do cross over. So,
the blog post that we put up today, July 29th, over on Facebook, which will eventually be over on the blog, thegateguys.com, we showed these kids with this significant crossing of the midline. And, the nervous system mirrors those contralateral upper and lower limbs, and you can train it to do that, and you can train it to work your way out of that. And if you're coaching and driving your own arm swing or your client's arm swing across the body, you're going to be coaching a narrow step from a neurologic perspective. It doesn't mean you can't not do that, crossing the arms and having your feet underneath you, but it's going to take some awareness and coaching of that awareness to your client. But you're kind of working against the nervous system, which is kind of the first half of our podcast today. Why not work with it? There's a reason why these things are shadowed in the upper and lower limbs, and it's because these are coordinated patterns for stability, balance, power, and the purity of the neurologic patterning. So I'm enjoying writing about these things. I always say this when I write about something, you've got to look at it a little more in depth, and I try to, as you do, throw in some research articles to substantiate it. And if I can't find an article to substantiate it, I start to ask myself, am I making this up because it makes sense to me and with what I've seen in my practice, or is there just no research out on this yet to substantiate it? And you and I, we tend to try to be honest with ourselves on these things, and when there isn't something, we tend to say, hey, well, what do we know? But this is what we see. So but this crossover stuff in these kids, I'm seeing more and more of it. And I've got a friend here locally who runs a camp with kids, and I was asking him and some of his sons about this, and I said, look, get out your camera, take some pictures for me, and start noticing this, and give me some insights on how frequently you see this, because they're doing camps of several hundred kids. So I'm waiting back for some answers on that, but I pretty much know what I think the answer is going to be, that it's out there, and the kids that run a little slower and look a little bit more clunky and mal-coordinated and a little bit more Dumbo-like are going to have this crossover type stuff, because they're not, it takes a lot more glute to abduct and externally rotate and position the limbs underneath you. And it's sloppy mechanics to just kind of collapse medially. Anybody can do that, but are you going to finesse the pattern and find some strength, or are you going to collapse into some weakness? We see that in a lot of our clients. So anyways, I think we're kind of dancing circles here at this point. Hey, one more thing, I just throw this out. I found that article, and we put this one up a couple weeks ago, on hip flexors, and we've been trying to find an old article about hip flexors being a swing phase perpetuator of the leg, as opposed to an initiator. We don't tend to use our hip flexors, which is primarily the iliacus and the psoas major minor. Those are your big hip flexors. They're certainly secondaries, but they're not as much for hip flexion in gait and running as you might think. They are perpetuators of swing at best. And this article was out of Danish Medical Journal, 2014, Contributions to the Understanding of Gait Control. We'll have this in the show notes for you, but their quote was, these experiments also showed that the trailing leg, meaning the leg that's behind your body and that has just helped you push off, is brought forward during the swing phase without activity in the flexor muscles about the hip joint. This was verified by the absence of EMG activity in the iliacus muscle, measured by intramuscular wire electrodes, which is really the only way to definitively see these things in an honest manner. So instead, the strong ligaments restricting hip joint extension are stretched during the first half of the swing phase, meaning while the leg is behind you in extension, thereby storing elastic energy, which is released during the last half of the stance phase, meaning as the leg's coming forward, thus accelerating the leg into the swing phase. This is considered an important energy-conserving feature in human walking. And we've always said that a lot of that is certainly there's the ligamentous and loading of these capsular tissues that helps spring the leg forward, but a lot of it is just the abdominals pulling the pelvis from that posterior position and obliquely pulling the pelvis forward via the stance phase leg, or on the stance phase leg, and that helps accelerate the pelvis forward, and then you get the whip-like effect of the leg coming through with the ligamentous structures releasing their energy, pulling the leg into flexion, and the hip flexor may help perpetuate that so that the leg is now forward without a lot of work through the hip flexor compartment. So Didn't know if you had any comment on that, but it was nice to get a more recent article, 2014. I think we'd been looking for that other article, at least I had been, and it was back in the late 90s, so it was nice to have something 20 years down the road to substantiate what we've been talking about here over time, because a lot of coaches and trainers are still forcing hip flexion through banded work and high knee stuff, and that needs to be driven by more abdominal than pure hip flexors. So it's okay to have some of these drills, but you need to know what you're doing with that drill, and it may not be training what you think you should be training. So once again, the more you know, the better you can train your client without creating some new problems. So
train your extensors.
Yes. All right, man. Good podcast. I enjoyed talking with you. We should do this more often. But
yeah,
Yeah, and we're going to start writing a little bit more again. You mentioned the other day, I actually asked you to look at one of my pieces, and you put in some valuable chunks that I didn't think about. So we'll start collaborating on stuff a little bit more, which will be nice. So that means the blog posts might become a little bit more orthopedic and neurologic, which I think makes them a little bit more comprehensive. So anyways, that's good. That's it for another podcast. I think this was 139. So I wanted to thank you guys for joining us here. We know your time is precious. We hope you listened to this on a run and used your toe extensors and your abdominals to perpetuate hip flexion. So, hey, we kind of did bring that whole thing full circle, didn't we?
We did.
We did. All right, buddy. Anything else you want to put in?
That's it, man.
That's it. I'm Sean Allen in Chicago.
I have a whirl up in Dillon, Colorado. Keep your head extended, your eyes open, and your toes extended. Take care.
Yes.